ambulatory antibiotics is for this otitis media. Surgical, myringotomy. Untreated can result in hearing loss. Nursing considerations. Prevent reoccurrence. Myringotomy is the incision and the tube placement is a tympanostomy. Infectious mononucleosis. It's characterized by increased mononuclear elements of the blood, general symptoms of infection process. Common amongst adolescents because they're always kissing, and they used to call it the kissing disease. Principal cause is Epstein-Barr virus. There's no special treatment. Instruct to limit exposure to members outside the family. So if your child is a teenager and they're in a relationship of kissing and hugging, you want to find out all the people they kissed because they could be very much infected with this mononucleosis. Croup syndromes. They're characterized by hoarseness, which is barking. They sound like a seal or like a dog. Their cough. Inspiratory stridor. What's an inspiratory stridor? When they breathe in, you can hear and it strides. It actually makes noise, really noise, and varying degrees of respiratory distress. Croup syndromes affect the larynx, the trachea, and the bronchi. Epiglottis, laryngitis, laryngeotracheal tracheobronchitis, LTB. Tracheolitis. There's immunization programs aimed at prevention. Follow along with me here, and we can put this up in your URL, and you'll be able to see and see this child with croup. Acute epiglottis. Clinical manifestations are sore throat, pain, tripod positioning, retractions, inspiratory stridor, mild hypoxia. What's hypoxia? Distress. Therapeutic management is potential for respiratory obstruction. Should not inspect throat unless intubation is possible. So that means we don't just, open up your throat and be sticking a tongue blade down there and looking at it. If you do not have a trach around and don't have anybody to put it in, don't do it. Nursing considerations. Tripod position. What's that tripod position? Drooling agitation and absence of cough are clinical symptoms. Prevention is the Hib vaccine, and that's given to children when they're born now. Acute laryngitis. More common in older children and adolescents, usually caused by a virus. The chief complaint is hoarseness, generally self-limiting, and without long-term sequelae. That means there's not any side effects from it. Treatment is symptomatic. Acute LTB. That's the laryngeotracheobronchiolitis. Most common in croup syndromes, generally affects children less than 5, and it comes from RSV, Barainian influenza, virus, Mycoplasma pneumoniae, and influenza A and B. You got an inspiratory stridor. Substernal retractions. What are substernal retractions? That's when the skin goes in between the ribs and you can actually see it caving in as they breathe. It looks like the skin's going to go right in their ribs. Barking or seal-like cough, increasing respiratory distress, and hypoxia can progress to respiratory acidosis, respiratory failure, and death. This is nothing to fool with. That's why they want you to have those trachs on hand. And we'll be showing you what respiratory distress looks like in a little while. Airway management, maintain hydration, PO or IV, high humidity with cool mist, nebulizer treatments, epinephrine and steroids. Acute spasmodic laryngitis, also known as spasmodic croup or midnight croup. Paroxysmal attacks of laryngeal obstruction. They occur chiefly at night. Their inflammation can be mild or absent. Most often affects children ages 1 to 3. Therapeutic management. Signs and symptoms of airway obstruction, increased pulse and respirations, sub, supra, and intercostal retractions. That means all the way from the bottom of your lung rib cage all the way up to the top. Flaring and restlessness, nasal flaring. Nasal flaring, I've actually seen their nose, their little nares go in and out, in and out. You can see them flare because they're really gasping for breath. And restlessness because they're hypoxic. Bacterial tracheolitis. Infection of the mucosa of the upper trachea. It's distinct entity with features of croup and epiglottitis. Clinical manifestations are similar to LTB. May be a complication of LTB. They get thick, purulent secretions, result in respiratory distress. So thinning those secretions, you can see why that's always the reason for using the mist and for keeping them hydrated. Therapeutic management. Humidified oxygen. Antipyretics, that means what? Antibiotics may require intubation. Infections of the lower airways, those were all upper. Considered the reactive portion of the lower respiratory tract. Includes bronchi, bronchioles, cartilaginous support not fully developed until adolescent. Construction of airways, constriction of the airways. And they can collapse very easily because they're so small. Bronchitis, also known as tracheobronchitis. Causative agents are viral agents. Clinical manifestations, their illness is from 5 to 8 days incubation. Once lower airway involved, wheezings, retractions, dyspnea. What's dyspnea? Tachypnea. What's tachypnea? And decreased breath sounds. Crackles, apnea is the first sign of RSV in infants. Bronchiolitis and RSV. RSV is respiratory syntactial virus. Pathophysiology. Prevention is prophylaxis. Nursing considerations. No nurse who is childbearing age should care for infants receiving ribavirin. Monitor their O2 levels and encourage breastfeeding. Bulb syringe the secretions and put them on a pulse ox. Pneumonias. There's lobar pneumonia, involves all or a large portion of the pulmonary lobes. Bronchopneumonia begins in terminal bronchioles. Where's terminal? Terminal is the lower end and goes to the lobes. Interstitial pneumonia is inflammation of the alveolar walls. Pneumonitis, inflammation of lung without infection of lumbar pneumonia. Lobar pneumonia. They're bacterial. They can be viral. You can have aspiration pneumonia, such as the child that's born with the meconium in the fluid when they're born. We worry about aspiration pneumonia of that. Histomycosis, coccidiomycosis, and other fungi, atypical pneumonias. Pertussis, whooping cough. It's why we get those DPT shots. The P is the pertussis. Caused by Bordetella pertussis. And in the United States, it most often occurs in children who have not been immunized. Highest incidence is in summer and spring. Highly contagious. Risk to young infants. And there are vaccines to DPT for sure. Tuberculosis, caused by Mycobacterium tuberculosis, human and bovine varieties. What's bovine? Transmission modes, usually airborne. Children usually get it from a family member. Clinical manifestations are ear infections, swollen lymph nodes, and inflammation of the lymph nodes on the skin. When they see that, that kind of sends up some little red flags. Pertussis, which is whooping cough, is caused. TB, recommended procedure is the Mantoux test. Uses purified protein derivative, PPD. Standard dose and administration technique. Positive reaction. If it's better than 5 millimeters in duration, 10 millimeters in duration, or 15 millimeters in duration. Recommendations for TB testing. Once you've been positive, you don't get PPDs anymore. You get a chest x-ray, and unless you are symptomatic, that should be sufficient for your records. It's treated with INH, rifampin, PZA. It's a 6-month regimen. Multi-drug resistant streptomycin, IM. Prophylaxis for high-risk patient is INH, 9 to 12 months. I saw this a lot when I did dosing in the Kent Counseling, where all the drug addicts came in for the Suboxone and Methadone. You see this a lot from them. And they are on plenty of them, and that's a state program. They have to answer to the state. They have to come and get their drugs, or the state will go out and be looking for them. Prognosis, most recover since use of antibiotics. Prevention, avoid contact with tubercular virus. And nursing considerations. You want to help the families to understand the role of diagnostics and treatments. Again, there we are educating. Foreign body aspiration. Risk amongst young children, especially young infants and children who place everything in their mouths. Diagnostic evaluation is x-ray or a bronchoscopy. What's a bronchoscopy? It's where they send down a light into that bronchial tube, and they look around to see what you've aspirated. Nursing consideration, child is choking when it cannot speak, becomes cyanotic, and collapses. Aspiration pneumonia, risk of the child with feeding difficulties. Think about your cleft lip, cleft palate, the cleft palate child. Prevent aspiration, feeding techniques, positioning. Avoid aspiration risks, oily nose drops, solvents, talcum powder. When we teach brand new moms on powdering their baby, we say cornstarch, we tell them, put it on your hand first. You're not dusting a chicken or flouring a chicken. You don't take the talcum